Hello friends, this is Mayuri Patel. So today we will see about the oligohydramnios. So let's see the definition of the oligohydramnia. So it is an extremely rare condition where the lichoremia is deficient in amount to the extent of less than 200 ml at term. Fine, in last lecture in polyhydramnia it was more than 2000 ml, and in this it is only less than 200 ml. Sonographically, if AFI is less than 5 centimeter, then it will call the oligohydramnia, and anhydramnia means there is no pocket of amnia, lichoremia means there is no lichoremia, that means anhydramnias. Next we'll see the etiology. So first we will see about the fetal condition, in that chromosomal. So if chromosomal abnormality is there, means there will be a chances of oligohydramnia. In polyhydramnia also we have seen कि because of chromosomal abnormality there was polyhydramnia. So in this also same. Second is renal agenesis, means there is a problem with the renal system. So urine production will be less. Next, obstructed ureapathy. If urinary tube or anything is obstructed in urinary system, that means if urine production is there, then also it is not coming out. Then spontaneous rupture of membrane. If spontaneously membrane is ruptured, so slightly or slowly the lichoremnia will be move out. Then IUGR and intrauterine infection. Drugs like PG and AC inhibitor. Post maturity, because of post maturity baby will swallow the lichoremnia or amniotic fluid. And amnion nodosum means there will be a failure of the secretion of the fluids from the placental membrane. Next we will see about the maternal condition. In this, first is hypertensive disorder, uteroplacental insufficiency, dehydration, and the idiopathy. Then diagnosis of the oligohydramnios. So in this, uterine size smaller than the gestational age. As soon as you will see the patient, you will come to know, or you will say there will be a problem with the gestational age and a smaller size of the uterine size of the uterus. Fine. The next is less fetal movement. Patient will feel less fetal movement because of fetal will not be moving inside the mother womb, because uh, amniotic fluid is less. Then uterus is full of fetus, because there will be a less amniotic fluid, so we will feel fetal parts more. Next, evidence of IUGR. Because of uterine insufficient uteroplacental insufficiency, there will be a problem with the exchange of the uh, nutrients or whatever it may be. There will be a less, so there the chances of IUGR will be there. Next is malpresentation. Because of amniotic fluid is less, so baby cannot move into the womb, so there will be a chances of the malpresentation. And last is USG. Through USG we will come to know what is AFI, and we will confirm the diagnosis. Next, complications. So first is in fetal abortion, deformities, fetal pulmonary hypoplasia. In deformities, mainly clubfoot. Then cord compression. Because of less amniotic fluid, there will be a chances of cord compression will be more. And lastly, high fetal mortality. Then maternal. In maternal, prolonged labor, and the next is increased operative interference. Next is management. In management, in first trimester, counseling and the serial USG to rule out the high risk. Then in the second trimester, counseling, amnio infusion, serial USG, exclude preterm, pre-rupture of membrane, and termination of the pregnancy SOS. In counseling, mainly we will tell how to take care or how to increase the amniotic fluid, or how to be healthy, or how to produce healthy baby. Fine. So in counseling we have to tell mother about the diet, hydration, then protein rich diet and all. In amnio infusion, we will infuse the fluid into the mother's womb, but directly intra abdominally or cervically, but it is performed less commonly nowadays. Then serial USG to rule out the any complication. and if preterm pre-rupture of membrane is there, means slowly the fluid will escape out, so that we have to exclude it. And lastly, if baby is term or any difficulty in baby's breathing or anything else is there, then any complications is there, then you should go for termination of the pregnancy. And the last, third trimester, if post-term case is there, then we should go for delivery serial USG. Then conservative management of preterm pre-rupture of membrane till 34 weeks of pregnancy. And the last, idiopathic cases like if we don't know the causes of oligohydramnios, then you have to go for serial NST and USG for the babies to know the baby's condition. Then lastly, the specific measures to increase the amniotic fluid. First of all, hydration, 1500 to 2000 ml per day, and the amnio infusion abdominally or transcervical. Nurses rule. We have to see about the concern, baseline FHR, vital signs, uterine activity, monitor FHR and uterine activity, measures and mark fundal height, and reassess every hourly. Notify if after giving solution of 800 ml, then also problem is not resolving and deceleration is there, then you have to notify the doctor. Or non-reassurance maternal fetal response is there, or if intrauterine pressure is greater than 25 mm of Hg. Then time of delivery. So according to the it depend on the according to fetal condition or specific conditions such as preeclampsia, growth retardation, fetal anomalies. These are the factors which according to that we will define what we should go for delivery or not. Then lastly, management of the labor. First is close monitoring, rupture of membrane in active phase of labor, amnio infusion in case of meconium stain. If FHR abnormalities, immediate CS you should go for. If baby is in hypoxia, then we can go for immediate CS. Nursing management, DFMC, daily fetal movement count. Left letter position, we have to tell patient to be in left letter position. FHR monitoring, administration of fluids, close monitoring during labor. This is a very small class. We have completed oligohydramnios. If any doubt, just comment it or message me. Thank you.